amiable welcome to everyone. This is our allied Lecdem channel to enhance your knowledge. Today's topic is about conduction system of the heart. The conduction system of the heart initiates and coordinates the electrical signal that causes rhythmic and synchronized contraction of the atria and the ventricles. This system comprises the SA node, AV node, and the wiring of the ventricles. The latter comprises the bundle of this, the left and the right bundle branches, and the Purkinje fibers. Failure in the function of these nodes or bundles leads to arrhythmias requiring electronic pacemaker implantation. On the other side, ectopic pacemaker or ectopic conduction activity may cause arrhythmias requiring intervention. Here we have the electrical system of the heart. The impulse originates from the SA node and travels to the AV node and reaches the bundle of is, and then gets divided into the right and left bundle branches and reaches the Purkinje fibers. Anatomy of the conduction system. The SINOATRIAL node. The SA node is a flat elliptical collection of specialized nodal tissues with dimension of up to 25 mm in length. This node is nestled in the superior posterolateral wall of the right atrium near the opening of the SVC, which is integrated by the sulcus terminalis. The sulcus terminalis is the junction of sinus venosus and the right atrium. Centrally, the SA node is populated with pale staining cells known as the cardiac pacemaker cells or the P cells. The SA node receives its blood supply from the sinoatrial nodal branch of the right coronary artery. Intranodal conduction pathway. The intranodal conduction pathways are a part of intra-atrial conduction network. Not only do these networks travel within the right atrium, but they also form the direct point of communications between the SA node and the AV nodes. The internodal conduction pathway is divided into anterior, middle, and the posterior branches. Anterior internodal pathway, Bachmann's pathway. The anterior internodal pathway originates from the anterior margin of the SA node. It continues anteriorly coursing around the SVC, where it gives off Bachmann's bundle. The anterior internodal band continues antero-inferiorly towards the AV node, where it enters the node by the way of its superior margin. The middle internodal pathway or the Wenckebach pathway. The middle internodal pathway arises from the posterior superior margin of the SA node. It continues behind the SVC towards the border of the interatrial septum. The pathway turns caudally in the interatrial septum to enter the AV node through its superior margin. Posterior internodal pathway or the thoral pathway. The posterior internodal pathway emerges from the posterior margin of the sinus node. It takes a posterior course around the superior vena cava and continues across the crista terminalis towards the Eustachian ridge, valve of IVC. The pathway then enters the intraatrial septum, where it enters the AV node through the posterior surface. These conduction pathways transmit the action potential slightly faster than the surrounding cardiomyocytes. They contain the Purkinje-like cells, which ensures that the action potential arrives the AV node at an appropriate time. Intraatrial conduction pathway. The intraatrial conduction pathway is also called the Bachmann's bundle, refers to the pathway of specialized cardiomyocytes that facilitate the conduction of impulse between the atria. This pathway branches from the anterior internodal pathway at the level of SVC. The Bachmann's bundle crosses the interatrial groove and passes over the limbus of fossa ovalis, a pad of fatty tissues that separates the Bachmann's bundle from the limbus. This pathway bifurcates into right and left branches that travels towards the right and left atrial auricles. The right branch can be further divided into superior arm and inferior arm. The superior arm originates at the external junction of the SVC and the atrium. The inferior arm emerges in the vestibule of the right atrium. The left branch provides some structural support to the anterior atrial wall and continues to wrap around the left atrial auricle. Proximally, the superior part of the left branch passes in front of the opening of the left pulmonary veins. The inferior part continues caudally in the vestibule of the left atrium. Histologically, the intra-atrial conduction pathway is a series of parallel strands of myocardium traveling in the subepicardiac layer. The myocytes within the Bachmann bundle are encased in thin septa made of tightly packed collagen fibrils. This uninterrupted sheath also forms interseptal connections. There are 5 identified cell types found within the intra-atrial pathway. They include the myofibril rich cells, the myofibril poor cells, the P cells, slender transitional cells, and the broad transitional cells. The presence of these specialized cells facilitates rapid conduction of action potential across the left atrium, minimizing the delay in depolarization between the atria. Bachmann's bundle receives its blood supply from the SA nodal branch of the RCA. Atrioventricular node. The AV node is often called as a secondary pacemaker of the heart. Under normal circumstances, it functions as a conduit of electrical activity from the SA node to the ventricles. It is the only pathway by which the action potential can cross from the atria to the ventricles, as the atrioventricular septum is made up of cartilaginous structure that is unable to conduct electrical impulses. The AV node is smaller than the SA node and is located in the postero-inferior part of the intra-atrial septum. Specifically, the nose rests in the Koch's triangle. This triangle is limited by the coronary sinus at the base, the septal leaflet of tricuspid valve at inferior, and the tendon of Tourado at superior. The hemi-oval shaped node occupies the subendocardiac layer within Koch's triangle. The base of this node also extends into the atrial muscle. The apex of the node extends antero-inferiorly. It passes through the fibrous cardiac skeleton to form the initial part of the atrioventricular or the bundle of its neck. The AV node receives its blood supply from the atrioventricular nodal branch of the distal RC. Like the SA nodal cells, the AV node cells also have adrenergic and cholinergic receptors in order to respond to autonomic input. The bundle of is. The is bundle is the initial segment of the AV node that penetrates to the fibrous trigone into the membranous part of the intraventricular septum. On transverse section at the level of the fibrous body, the is bundle may appear oval or triangular. A unique and important feature of this is bundle is that it only allows forward movement of action potential. Therefore, the retrograde transmission of electrical impulse from the ventricles to the atria is not allowed in normal functioning heart. The AV bundle is separated by the anterior and inferior intraventricular branch. The right and the left bundle branches. As the node moves from the membranous to muscular intraventricular septum, it bifurcates into right bundle branch and the left bundle branches. The right bundle branch. The right bundle branch emerges from the AV bundle in the membranous intraventricular septum. It is a round group of narrow fascicles that travel in the myocardium before moving superficially to the subendocardiac layer space. It travels to the right side of the intraventricular septum, where it gives off branches to the ventricular walls before going on towards the apex. Here it then enters the septomarginal quadrator band before reaching the anterior papillary muscle. The terminal arborization or the terminal branches of the right bundle branch supplies the papillary muscle and recurs to supply the rest of the ventricular walls. The left bundle branch. The left bundle branch branches from the atrioventricular bundle at the start of the muscular IVS. It is made up of numerous small fascicles that become flattened sheets. These fascicles occupy the left half of the muscular intraventricular septum. The sheath moves to the subendocardiac space as it travels towards the ventricular apex. There, it trifurcates into posterior, septal, and anterior divisions. But it is referred that the left bundle branch gives off left anterior fascicle and the left posterior fascicle in most cases. The branches will go on and activate the anterior and posterior papillary muscles, intraventricular septum, and the walls of the left ventricle. Purkinje fibers. The right and the left bundles are populated with subendocardial branches. These cells can be much larger than those of the surrounding heart muscles, and they function quite differently than preceding cells of the AV node. Subendocardial branches are found throughout the entire length of both bundles in the subendocardiac layer. They extend towards the cardiac apex, then curve upward and backward through the walls of the ventricles. The Fries fibers have far more gap junctions than the AV nodal cells and the surrounding myocytes. As a result, they are able to transmit impulses 6 times faster than the ventricular muscles and 150 times faster than the AV nodal fibers. The increased number of gap junctions allow more ions to pass from one cell to the next, thus increasing the rate of conduction. There are fewer myofibrils in Purkinje cells, resulting in little contraction within these cells. Consequently, the bundles can achieve almost instantaneous transmission of action potential to rest of the ventricles once it passes through the AV node. This compensates the delay at the AV node and allows the ventricle to contract shortly after the atria. Note that the main branches of the atrioventricular bundle are insulated by sheets of connective tissues. This prevents premature excitation of the adjacent cardiac tissues. Therefore, the papillary muscles will depolarize first, followed by the ventricular apex, then the walls. The pattern of depolarization also goes from endocardium to epicardium since the fibers are in subendocardiac layer. Next is about the physiology of the conduction system. Here we are going to discuss about the action potential. The phase 0, which is indicated in blue color, is known as the depolarization phase, where the voltage-gated sodium channels open. And the phase 1, indicated at the peak of the action potential curve, is referred to as the initial repolarization phase, where the sodium channel closes and the voltage-gated potassium channels begins to open. And the phase 2, which is indicated in orange color. Here, the voltage-gated calcium channels open along with the potassium efflux continues. This is known as a plateau phase in which the myocytes undergo contraction. And the next is the phase 3, which is indicated in green color. This is the rapid repolarization phase, where the calcium channel closes and the slow voltage-gated potassium channels open. And the phase 4 is a relative potential period where there is high potassium permeability. The refractory period is referred to as that, and second action potential cannot be initiated, that is an inactive period. The SINOATRIAL node. The cardiomyocytes have the special ability to stimulate themselves. The initiation of the action potential is dependent on ion channels that allow passage of ions in and out of the cells. The case of cardiomyocytes, they have fast-acting sodium ions, slow sodium calcium ions, and slow and fast potassium ion channels. This atomicity is particularly enhanced in P cells. They have lower resting membrane potentials than the surrounding cardiomyocyte and transition cells due to the following factors. The factors are: there is higher concentration of extracellular sodium outside the nodal fibers. A relatively large amount of sodium channels are already open. There is passive diffusion of Na+ into the P cells between heartbeats due to the presence of leaky sodium channels. The passive influx of sodium causes a slow rise in the membrane potentials of the cells, bringing it progressively closer to the generation threshold of action potential. Therefore, the cardiac P cells of the SA node are almost readily depolarized than the other cardiac cells. The SA node is also intimately connected with the surrounding heart muscles via the internodal and intra-atrial conduction pathways, which we discussed earlier. Consequently, the generated action potential can be rapidly transmitted to other cells. This enables the SA node to set a pace at which the heart cells will depolarize and subsequently contract, making it the pacemaker of the heart. On average, the SA node can fire between 60 to 100 beats per minute. Atrioventricular node. The main role of the AV node is to facilitate passage of the depolarization wave to the ventricles. It also has additional functions. In the absence of functioning SA node, the AV node has the ability to take over as pacemaker of the heart. We also know that it also has P cells that are able to establish a slower rhythm. The AV node is also responsible for slowing down the passage of electrical impulse traveling to the ventricles. This important phenomenon allows more time for the ventricle to remain quiescent or fill blood coming from the contracting atria. One key feature of the transition cells and P cells in the AV node is that they have fewer gap junctions and intercalated discs. Consequently, there is more resistance to conduction in this part of conduction pathway than any other areas. Autonomic regulation. The entire cardiac conduction system is under the influence of autonomic pathway. It is of two: sympathetic stimulation and parasympathetic stimulation. The sympathetic stimulation of the conduction tissue comes from the cardiac plexus, and the parasympathetic influence arises from the vagus nerve. Sympathetic activation. The activation of the sympathetic nervous system results in the release of adrenaline and other adrenergic neurochemicals. They bind to beta-1 and beta-2 receptors found in both SA node and AV node, as well as the supporting conduction pathways. The overall impact of the sympathetic system is to increase the depolarization rate of the SA node. This elevates the overall heart rate, increased chronotrophy. Since these adrenergic receptors are also present in cardiomyocytes, the sympathetic drive will act on these cells, increasing the contraction force, increased angiotrophy. Therefore, the overall cardiac output will be increased. Parasympathetic activation. The parasympathetic activation of muscarinic receptors at the SA node and the AV node will have opposite effect when compared to sympathetic system. Parasympathetic stimulation slows down SA node activation, thus reducing the heart rate. It also reduces the contractility of cardiomyocytes, effectively reducing the cardiac output. And on the next slide, we are going to have a small recap about today's topic. In the first diagram, we can see the impulse originates from the SA node. Coming to the second one, the action potentials are conducted from the SA node to the atrial muscles. And in 3, the action potential spreads through the atria and reaches the AV node where the conduction slows down. And in 4, the action potential travels rapidly through the conduction system to the apex of the heart via the bundle branches and the wiring of the ventricles. And in 5, the action potential spreads upward through the ventricular muscles. And in 6, eventually the entire heart has returned to the resting state, remaining there until any other action potential is generated in the SA node. Now we are going to interrupt this with ECG. So in diagram 1, it denotes the beginning of impulse conduction. Coming to 2, the SA node and the atrial wall depolarizes, which is reflected by the P wave. And in 3, the atrial walls are completely depolarized and there is no change recorded in the ECG reflected by the PR interval. And in the 4, we can see the appearance of QRS complex as the atria as repolarized and the ventricular walls depolarize. And in the 5th diagram, we can see the ventricular walls are completely depolarized and there is no change in the ECG. And in 6, there is appearance of T wave, which indicates the ventricular walls have depolarized. Thank you.